I'm sitting down today with Nancy Rosen Cohen, who is the Executive Director of the Maryland chapter of the National Council of Alcoholism and Drug Dependence. Thank you so much for coming and joining us today as part of the larger harm reduction conference. We really appreciate it. So tell me about your organization and the work you do on issues of addiction treatment and drug policy.
Absolutely. Our organization was formulated, a national organization, in 1944 when it was the National Council on Alcoholism. And then in the 70s it changed to National Council on Alcoholism and Drug Dependence. There are 91 chapters across the country, and I'm the Executive Director of the Maryland chapter. We're an advocacy organization that represents people in recovery, people needing to be in recovery, and people in treatment. So we work with individuals. We have two separate programs. One is called the Recovery Leadership Program, which is a program where we train individuals that are in recovery to become their own best advocates. And so we work with legislators in Annapolis, and then we train our individuals that are in recovery to speak and tell their story and to influence policy decisions.
Sure.
Another part, an outgrowth of that program is called Peer Workforce Initiative, where we train peer specialists to be in hospital settings and to be in parole and probation, to be in the drug courts, and so that's a new program that we're doing.
Okay.
So we're very proud of that. And another program that we have that we're very proud of in the state of Maryland is what we call our Families for Recovery. So it's family members that are either going through a situation with their son or daughter or relative, or has already lost someone to a heroin overdose or an opiate overdose. And we support the family programs around the state and help to influence legislation. And in the last 2 years, we've been able to we've been influential in the passing of the naloxone bill, the drug that reverses the opiate overdose, and then the Good Samaritan Law.
Okay.
And the Good Samaritan Law basically was changed last year. We're encouraging individuals, if there was someone who was overdosed, that we encourage them to call 911 for help. 2 years ago, it was that you would be arrested but not prosecuted. Last year, because of our family involvement and other groups that we work with, that we partner with, it's now changed that you would not be arrested if you made that call to save a person's life, or prosecuted. So that was it was a great stride that we made, and I do believe as an advocacy organization in the state of Maryland, we've had some great influence with policymakers like Dr. Dan Morheim has really been very helpful with us, and we've had some very good supporters in the legislative field in Annapolis, Maryland.
Fantastic. So from your perspective, what needs to be done to address the problems of drug addiction and drug-related violence in the United States, and Maryland more specifically?
Well, I look at the drug policy situation as my answer would be, a short answer would be that we need to look at it as a public health drug policy strategy. We do look at this addiction as a brain disease, and it has to be treated in the public health sector, and it's certainly, with the arrest record being what it is, being punitive is not the answer by any means. We have to come up with an alternative to that, and there has to be diversion from that. So I look at it as a public health strategy, and I have several points that I feel are important. Prevention, certainly if we can start in the younger years, the third and fourth grade in the school systems, we have a program called SBIRT, which is Screening, Brief Intervention, Referral to Treatment, SBIRT. We're encouraging physicians to use that as part of their, primary care physicians to use that as part of their 15-minute evaluation of an individual, but we'd like it to be in the school systems as well. So prevention is a very key factor. Intervention, so that we can intervene with families and children, whether it be through a hotline service or whether it be through the school systems or in hospital settings. And then we talk about as I say, we talk about prevention, intervention, treatment. And we do know that treatment works. I'm in the work group now with treatment on demand. And we need to offer treatment to people, whether it be before they enter the prison system, while they're in the prison system, certainly when they're in a hospital setting, if we can divert them out of the emergency room, repeat emergency room visits, and take them into treatment programs, that's important. And another aspect that really needs to be looked at is this whole process of recovery. People coming out of treatment, let's say a 28-day treatment program, do need that support services of case management and recovery support services, and then peer recovery training. And the last thing is public safety, of course. We want to certainly work with police officers. I know in the city of Baltimore, Dr. Wen, the health commissioner, has done an excellent job with training police officers on the utilization of naloxone. And we also have 2 different programs going on where they're working with caseworkers to divert people from being arrested, certainly, if they need treatment. So there are some programs that are being done in the Baltimore area that are being very successful. It's now become a statewide problem because of the heroin overdose and the opiate overdose. We still have, more so in this country than in other countries, we have that prescription drug overdose situation. And so our job really as advocates is to work with the primary care physicians. And if an individual goes in for treatment or goes into the primary care physician, let's say with an injury, a sports injury, and they say they're in recovery, we don't want the doctor to give them 30 Oxycontins instead of 90. So state of Maryland has a very strong prescription drug monitoring program that just became in effect, I would say, a couple years ago, but they're really working very hard on that. So I think there's a lot of strong things happening in the state of Maryland, and I think we're fortunate to live here because I think in many ways we're very much ahead of some other states in some of our policy work and some of our advocacy work.
So, you mentioned that, I think for good reason, thinking about our neighbors both to the north and to the south. And although D.C. is ahead of us in some ways, maybe not as far in others.
Right.
And a lot of these issues are deeply controversial.
Exactly.
And controversial across rural versus urban.
Absolutely.
And increasingly political, unfortunately.
Yes.
What do you think needs to be done in order to make meaningful progress on these issues more broadly in the United States?
Well, I think I think it's about education and it's about outreach. I think we have to get people to understand that addiction is a disease and it's a family disease. It doesn't just take the person down that is involved. It affects the whole family, affects your work, it affects certainly your housing situation. If people would understand, if individuals and policymakers would understand that if you make a comparison to, let's say, diabetes, if someone's diabetic, you certainly keep them on a regimen of insulin. If they would understand that this is a brain disease that's not going away and it's not necessarily by choice, as some people used to think it's a behavioral choice, it is an addiction. I think by changing the language and helping people to understand and not be so afraid of the situation, again, back to my original statement, if it's looked at, the drug policy situation in the United States, if it's looked at as a public health crisis, then I think that you will get more people to, how should I say, be on board with it because they understand that young people are losing their lives. There's no question about it. And even the elderly population, there is a strong preference for the elderly population to have opiates prescribed. And we really have to work on changing that. So it's the public health system that we have to change as well as, the legal system and the, criminal justice system. The whole dialogue needs to change.
So how does the National Council on Alcoholism and Drug Dependence fit into into conferences like the Harm Reduction Conference and really changing the dialogue and the tone of the conversation around drug addiction and treatment?
Well, a good example is I'm in the work group that's treatment on demand, and that's a relatively new concept because, as you know, if you have a physical problem, a somatic problem, you'll go to a support group for that somatic problem. You'll go to a primary care and you'll go to a physician's assistant, and you'll get what you need as an individual. In our case, the individuals that are suffering, really, they don't have it set up, the system isn't set up yet for them as well. So, for instance, treatment on demand means if someone goes into the emergency room and you want to redirect them out of that emergency room, I'm not talking about somebody who's going through an overdose, but I'm talking about somebody that needs treatment, then we would like to employ in that emergency room peer recovery specialists to redirect that person into treatment. You can also redirect people into treatment through the parole and probation programs rather than locking them up. Also, there are some drug courts that believe in diverting people to treatment programs as well. So if we look at it as a disease and we look at it as a public health issue and a public health crisis, I think people will start to understand that more and be a little more accepting. And rather than right now, we're just dealing with the crisis end of it. The number of, I think the numbers are varying in the city of heroin addicted individuals. They say it's 16,000 or 22,000. We understand that, but if we can really get them treatment on demand and we can get them access to that treatment, and that some of the regulations change a little bit to make it easier for individuals, then I think we'll be in much better shape.
Great. Nancy, thank you so much for joining us today. We
Thank
really
you so
appreciate
much.
it.
I appreciate it.